Good afternoon, everyone. Thank you for joining us again today. My name is Dr. Indamala Ofsui, and with me here is Dr. Nico Osaji. I'm a consultant physician on internal medicine, and Dr. Nico is a consultant obstetrician and gynecologist. So this afternoon, we'll be having a very fruitful discussion, hopefully, on the evaluation and management of diabetes mellitus in pregnancy. Good afternoon, Dr. Nico.
Good afternoon. Welcome everybody to this discussion.
So what should our audience be expecting today? What kind of expectations should they have?
Yes, from what we'll be extensively discussing today, we'll be discussing about the management, proper management of the diabetic and of course the gestational diabetic patient in pregnancy. We'll also expect to know tips or have tips on how we can easily pick out complications and to ensure that there's good maternal and fetal outcome.
Okay, so I think that's a fair expectation and that's a fair introduction. It will be an interactive discussion, and I think we just get right to it without wasting so much more time. This is already 8 minutes past 3, and the webinar is slated for 3. So once again, we thank everybody else for joining us. Let me find the presentation slide just now. Just a moment. Okay, so yes, so here's the topic, and so here we go. So basically, we'll be talking about evaluation and management of diabetes in pregnancy today. And I'm sure you all agree with me that diabetes is actually increasingly more and more common. Perhaps every week, I probably see up to between 5 and 10 patients with newly diagnosed diabetes. That's the range. I'm sure each and every one of us, we know a lot of more and more people that have diabetes as well. And mirroring this increasing prevalence of diabetes in pregnancy is also increasing as well, because they actually just go hand in hand together. So for this presentation, we're actually going to follow this outline. We'll try to cover all these areas to a variable extent. Hopefully God help us. Introduction, classification and epidemiology, pathophysiology, risk factors, complications, comorbidities, and just all the way down. And hopefully we hope that at the end of the discussion, that we all are better off in one way or the other in the way we approach patients that is found to have diabetes in pregnancy. So Dr. Nico, by the way of introduction, what is, just summary, what's diabetes and what's diabetes in pregnancy? How should we approach that?
Thank you so much. Well, diabetes in pregnancy has undergone a lot of changes, consensus, due to the fact that a lot of bodies have been concerned about the outcome in pregnancy, monitoring techniques, the threshold for diagnosis, etc. So prior to now, we defined it as any glucose intolerance peaked for the first time in pregnancy or even the onset in pregnancy. However, this left out a lot of categories of women. A woman who has never had the opportunity to be in the hospital diagnosed as diabetic before, she just comes in and you diagnose her. And instead of focusing on if she's diabetic, you now decide she has gestational diabetes. So a lot of groups came together, FIGO, ID, the International Association of Diabetes Study in Pregnant Women, and a lot of NICE as well. And they finally came up with a consensus, and this consensus defines gestational diabetes as the onset of hyperglycemia during pregnancy that does not meet the criteria for diabetes in pregnancy.
Okay.
While a diabetic woman is still classified using the WHO classification of criteria for diabetes in pregnancy, which we'll be looking at subsequently during the discussion.
Okay, so basically, if someone has hyperglycemia in pregnancy, but it doesn't meet the traditional criteria for making a diagnosis of diabetes mellitus, yes, we call it gestational diabetes.
Yes.
That's one. And usually, from this slides now, usually gestational diabetes is actually something that typically has its onset from about mid-pregnancy, about 24 weeks of pregnancy. Yes. And using that term, it means that it doesn't quite meet the criteria for defining diabetes, and it's not quite normal. So it's actually some extent of glucose intolerance, but not intolerant enough to be called diabetes. So that means it's a milder form of hyperglycemia compared to diabetes mellitus, or to pre-gestational diabetes mellitus. Okay, so, and it's important to recognize this category because people who have diabetes existing before pregnancy, they know that they have diabetes. They probably should have been taking some certain precautions. I mean, their glucose control, you know, that they check this, they'll do this, they'll do that. Gestational diabetes mellitus, it creeps up to you inside pregnancy, and you didn't know, you were quite normal before actually. And pregnancy, we assume, is a physiological state. And here is this glycemia going up. So it's actually important that we recognize it because it's associated with a high risk of poor pregnancy outcomes, right?
Yes.
And apart from the high risk of poor pregnancy outcomes, there's a risk in the future for diabetes, for cardiovascular disease, both in the mother and actually in the fetus.
Yes.
So that is the reason why we actually need to talk about this, and we need to make sure that we're giving our patients the best care when they have diabetes happening in their pregnancy. Okay, so basically, before we go deep into GDM, we just need to talk about an overview of how we classify diabetes mellitus.
Yeah.
So how do we classify diabetes mellitus?
So the different categories of diabetes mellitus includes, okay, we'll separate them. One, the type 1.
Yes.
The type 1, which previously used to be called that of the young, but we are seeing a lot of young people getting type 2 diabetes. And this is usually genetically predisposed. And of course, environmental factor, lifestyle also plays a role. And then the type 2 diabetes,
which is a common type of diabetes that we all see every time.
Yes. And then, of course, the other specific types
of diabetes, the ones that are due to pancreatic issues, detoxification, and all of them, and then the gestational diabetes. It's important that any one of all these kind of diabetes can coexist with pregnancy, because anybody with diabetes can get pregnant. Absolutely. And then we are having more and more type 2 diabetes in pregnancy now, because type 2 diabetes is getting more frequent and it's happening at a younger age. Okay, so any of these any of these first three types of diabetes that we did mention, that's the type 1, type 2, and the specific type of diabetes can actually all happen in pregnancy. But for the gestational diabetes, of course, there's a type that is specific to pregnancy, and we know that by definition, usually gestational diabetes usually results after pregnancy, even though, of course, it's not always the case. Okay, but in pregnancy, someone can have pre-gestational diabetes, which can be any of these other types, usually type 1 or type 2, most commonly type 2. And of course, we can have the gestational diabetes. And you've explained the difference between the two. In gestational diabetes, the glucose intolerance that is being diagnosed for the first time in pregnancy is actually not high enough to be called diabetes. If it's high enough to be called diabetes, you just call it diabetes in pregnancy, actually. Whether you know the type or not is now another kettle of fish. So what can you tell us about the epidemiology of diabetes in pregnancy?
Yeah, so this is a public health issue. It's a priority, in fact, because of the associated maternal and fetal outcome, and also the complications in pregnancy, which can be picked and managed during pregnancy. And of course, we are talking about the double burden disorder right now, because in low-income countries, you see, there's this perception that it's usually the malnutrition and the complications from that, etc. However, we are even seeing more cases of non-communicable diseases, and diabetes contributes a very, very important percentage of prevalence to this.
But why do you think we are seeing more diabetes in pregnancy these days? Because while I was doing residency, for example, I don't think the proportion of it's getting higher. That's the truth.
Yeah,
why do you think it's going higher?
I also observed that. You see, our lifestyle is changing. Most of us, we have white collar job. We come in, we sit down all day, we go back home, we lie down, and then we sleep. Our eating habits, we don't really have, the right proportion of nutrients in our diet. We have fast food, etc., etc. And then we really have little or no time for exercise, which is so important. And this has been recognized by the various bodies, and this has been included in various thresholds that increased overweight and obesity has increased the risk. And also women of reproductive age, the age at which women get pregnant is really increasing nowadays, because people prefer to, well, let's focus on our career
going to
first,
school,
going to
career,
school, getting
finances.
financially independent
Absolutely.
before you embark on the journey of pregnancy. And so this is a timely subject which we are embarking on right now.
Okay, so thank you so very much for that, Dr. So how common, based on data that's available, how common is gestational diabetes, talking gestational diabetes itself at this time? How common would you say it is?
Yeah, so from global prevalence, we have a prevalence rate of 3 to 14%. However, there's been isolated studies meaning that in a particular region, a particular hospital, we in a hospital, I think we did a study that was like 2 years ago, and we found different prevalence rate. So this has contributed to the wide range of prevalence. However, globally, it's known to be 3 to 14% of pregnancy, not to occur in 3 to 14%.
Absolutely, yeah. And part of the reasons why we have quite a wide variability of the prevalence that will be quoted is because different bodies use different diagnostic threshold. The diagnostic threshold that has varied over the years. These days, we use more quite stringent cutoffs because we want to actually pick up a lot of them so that less mothers have complications and less babies have complications. And of course, if you check, just like the prevalence of diabetes is higher in urban areas compared to rural areas. And of course, in community studies, you have a lower prevalence compared to if you're doing a study in the outpatient clinic of a teaching hospital, for example, where more referral patients are coming to. Okay, but out of all the cases of DM in pregnancy, we know that vast majority is GDM. Of course, there are many reasons that account for this. We know that the prevalence of type 2 diabetes increases with age. Most people, the risk of DM is actually higher in postmenopausal people compared to premenopausal people. So, but GDM actually happens during pregnancy. So, out of all the DM in pregnancy, we have majority is GDM, and then a smaller amount of the remaining will be type 2 diabetes in pregnancy for people who have type 2 diabetes fairly early, and some will be type 1 diabetes, while some others will be the other specific types of diabetes mellitus. It's also important, this data from the UK, that out of all the CS they did, about 67% were actually with diabetes in pregnancy.
That's quite high.
It's quite high.
Higher than the allowed cutoff by WHO, which should be at least 15%, less than 15%. So this really is a timely topic, and it's good we're having this discussion.
Absolutely. And so talking about the pathophysiology of diabetes in pregnancy, particularly talking about GDM now, but even broadly about diabetes in pregnancy, how does this happen? How does someone's sugar go up in pregnancy? And what are the consequences? How do those consequences arise? We know, talking about pre-gestational diabetes, first of all, we know that in people that have hyperglycemia at the time of conception and at the early period of embryogenesis, the risk of complication is extremely very high. That's one thing to note. And of course, we know that hyperglycemia is teratogenic, so to say. Okay, that's one. And of course, beyond the period of embryogenesis, during the period of organogenesis, the risk of spontaneous abortion and congenital abnormalities is extremely high. I've seen a patient before, I think I saw her late last year. She had actually had about 3 miscarriages before, all late first trimester, early second trimester. And nobody really ever did a proper OGTT for her. And thankfully, the time I screened her, she was out of pregnancy at that time. Glucose was just slightly impaired, but by the time she came in pregnancy and she fasting and postprandial was down, actually postprandial was quite high, and she made the diagnostic criteria for even DM in pregnancy, not even gestational diabetes. So basically, we can have all those kind of outcomes when hyperglycemia exists in early pregnancy. The risk of spontaneous abortion is very high, and the risk of congenital abnormalities is very high as well.
Yeah, to bring the point really down home, you see, in diabetes, what happens is that there's insulin resistance or reduced sensitivity at the peripheral cells. And so at the level of in the liver, what happens is that there's increasing breakdown of glycogen to glucose because the cells are not getting the glucose.
Yes.
And so the liver perceives, okay, I need to produce more.
Absolutely.
And so it creates a hyperglycemic environment extracellularly. Now, this glucose can easily be transported into the fetus because through facilitated diffusion. However, because the insulin in the mother is still at a level that it's not really in quotes, usable, the fetus now gets this high glucose, and then there's hyperinsulinemia in the fetus, and then it leads to all the manifestations we see.
Absolutely.
And like you rightly said, hyperglycemia is teratogenic. And that is why it was so important to distinguish between diabetes in pregnancy and gestational diabetes. Because when you have hyperglycemia, during that point of organogenesis and subsequent, especially organogenesis, you usually get the consequences of that, which includes spontaneous abortion, congenital abnormality.
There's a woman sadly managed a couple of years ago. She had pre-existing diabetes before pregnancy, and the baby had congenital abnormalities of the heart. Actually, it was sad. Eventually, she lost the baby, but before she lost the baby, she actually spent millions trying to sort her out, incubator care, ventilator, and all of those things, and it's sad. So this spontaneous abortion and congenital anomalies, they're actually real issues, and they are issues that we can actually do something to totally prevent.
Yes.
Now, in normal pregnancy, there are actually a number of metabolic changes that occur in normal pregnancy, and these changes are actually homeostatic. They are designed to help the baby, so to say, and then to prepare the mother for the rest of pregnancy and prepare the mother for delivery, etc., etc. So number one is that, of course, we know we have a growing fetus somewhere. The fetus is at a disadvantage, and naturally, nature and God have to do something to make sure that the baby can get a continuous supply of glucose, such that the baby can grow the way the baby is supposed to grow. And of course, apart from that, there is a need to meet the physiological needs of the woman during pregnancy itself, delivery, and lactation. So there are a lot of hormonal changes that happen that actually has anti-insulin effects in the mother, such that the glucose level can be high enough for enough glucose to be able to flow to the fetus. Because if the mother is actually mopping up all the glucose, then that means that there will not be enough glucose to go to the baby.
Yeah.
Okay, so the baby is like a parasite that compulsorily gets nutrients from the mother, irrespective of how much the mother is able to eat or otherwise. Actually, so in pregnancy, actually, there is a initial brief increase in insulin sensitivity. Okay, but after the first few weeks of pregnancy, there's actually a more insulin resistant environment within the mother, and that's especially there in the second and third trimester.
Now, this resistance, like you said, is brought about by, after 20 weeks, 24 weeks, there's increase in some anti-insulin hormones, the human placenta lactogen, progesterone, estrogen, etc.
Absolutely.
These have their own functions in pregnancy. Yeah. However, with regards to insulin and then glucose metabolism,
it counters it.
Yes, it counters it.
Okay.
And this is very important during the monitoring, because it will now give rise to, it will now help us understand why at particular point in pregnancy we need to do some form of monitoring.
Absolutely. And because of the continual fetal uptake as well of glucose, actually pregnant women, the reference rate for glucose actually is slightly lower in pregnant women. And that's of course why the diagnostic threshold for diagnosing GDM is lower than what we have in non-pregnant people. So in a normal pregnant person, actually the glucose actually goes a little bit lower because the fetus is taken from the mother. And so basically like that. And of course, there's also a lower renal threshold for glucose excretion in pregnancy. And that's why you can easily see glycosuria in a pregnant woman without it necessarily meaning hyperglycemia. However, of course, we know that if someone has persistent glycosuria or severe glycosuria in pregnancy, it can be something that should prompt us to screen for hyperglycemia. Yes. So while we have these normal physiological changes in normal pregnancy, in people with diabetes, either diabetes predating pregnancy or diabetes that develops during pregnancy, it's slightly different. It's slightly different. So while we describe here on this slide that there is some insulin resistance in pregnancy, particularly in the second and third trimester after 24 weeks, like Dr. Nicole said, in normal people, the mother produces up to the game of the insulin production. So insulin production goes up and is able to still keep the maternal glucose level under control. Okay, so insulin secretion goes up. But in people in which the beta cells are insufficient before, so there's beta cell insufficiency, either some type 1 diabetes or someone that has tendency for diabetes, or people who have some background insulin resistance before, the amount of insulin they're producing will not be able to overcome this resistance And of course, they will start developing postprandial hyperglycemia. So that means the amount of insulin they release following a meal will not be enough to mop up the glucose surge that will happen. And it's important to know this because in gestational diabetes particularly, the major defect we have is actually postprandial hyperglycemia. The fastings are usually not terribly problematic. Okay, so in addition to postprandial hyperglycemia, we can also have fetal hyperinsulinemia. So the baby's insulin level in the baby goes up, just trying to catch up with that hyperglycemia. Unfortunately, that will usually invariably lead to increased proliferation of tissue, increased growth of tissues in the baby.
Position of parts.
Absolutely.
I know why it's so important to understand this. You know, the glucose can be transferred by the placenta, but the insulin can't.
Oh, yeah.
Because of the molecular weight.
Absolutely.
And so the baby now steps up because of the hyperglycemic environment to produce more insulin, hyperinsulinemia. Insulin is a growth factor.
It's a growth factor. It's an anabolic hormone.
The position of
fats and tissues everywhere, and that leads to this macrosomia.
Yes.
Okay, and of course, many studies have shown also that it leads to all this fetal stress phenomenon, hypoxia, hypothalamic. So that's why you're more likely to have fetal distress and many other things. And that vascular sludging from polycythemia, particularly, is one of the things that predispose people with diabetes in pregnancy to growth retardation and fetal death sometimes. So they can have all of those phenomena, and basically all these things are the things that happen in someone that has diabetes in pregnancy. And of course, when we're treating patients with diabetes in pregnancy, those are the kind of things that we have to put in mind so that we treat the patient holistically and we understand the rationale for many of the treatment points we're making. So Dr. Nicole, which patients are likely to have diabetes in pregnancy? What are the major risk factors we have for gestational diabetes or diabetes in pregnancy?
Yeah, so these risk factors not only tells us which of the patients that we should look out for and recommend continuous screening for. However, they also increase our index of suspicion and then get us into the mode of screening and all that. So women that are greater than 35 years old, because of course, as you progress in age, add on in age, there's increased incidence of metabolic disorders. Diabetes is one of them.
Okay.
Also, BMI greater than 90. Of course, when you have increased deposition of fat in the tissue, that one is also an increased risk to the patient. Of course, we convert it to 90 kg as well. And then, of course, what we subtly don't remember is this increased weight gain. So there's been stated categories of weight gain that is allowed.
That's appropriate in pregnancy.
Yes, healthy in every trimester. So we have to also watch out for that as well.
So any patient that gains weight very rapidly in pregnancy, we should watch out that this person has a high risk for DME pregnancy. And if they, so there are those trimester-specific amounts of weight you should gain, depending on whether you are underweight, normal weight, overweight, or obese. So if the patient is exceeding that, even if you didn't see any other risk factor before, it probably should prompt you to screen to know disease for the patient.
And in addition to this, ethnicity, people from non-Hispanic region.
But coming down to Nigeria, I actually take it that sub-Saharan Africans are high risk for DME.
Although we don't have the well, that's true.
Okay, so which other risk factors would you talk about?
So we also, like we rightly spoke about earlier on, persistent glycosuria. Yes, there's a reduced renal threshold. However, when it's persistent and also the amount of glycosuria increases, then we should screen. Then fetal wastage. Fetal wastage in form of unexplained fetal deaths, stillbirths, previous history of all these. Also, the miscarriages, like that patient you spoke about, that you timely screened and you, so all these. Now, previous history of macrosomia is also one of the risk factors. A woman that's had recurrent miscarriage and also a previous history of congenital anomaly. Family history in the first degree relative, your mom, your dad, or perhaps your sister, very not too strong with the same, but however, if it's in your grandparents, that's second degree. So first degree relative will be a very one of the risk factors. Then also polyhydramnios, which means increased amniotic fluid index of greater than 2,000, depending on the trimester 2 recently, or greater than 2,000 mils. also is a pointer to one of the risks. And then this recurrent vulvovaginitis, it's one of the risk factors, recurrent history of urinary tract infection, and also a previous history of gestational diabetes. Now, multi-fetal pregnancy, because of the increased amount of hormones, anti-insulin hormones that we just spoke about, could also predispose a woman. So really, a woman between triplet gestation should really be also screened. There are other risk factors, but as we go along, we'll be talking about them.
Absolutely. So part of the risk factors that people often forget is also people that have previous history of gestational diabetes. So someone has had GDM before. Unfortunately, women tend to forget this sometimes. Someone has had GDM before 2 or 3 pregnancies ago, and then because the stuff has apparently looked as though it's quiet, they just don't make any big deal out of it again, and they just totally forget that this ever happened to them. So those kind of patients as well should be screened for gestational diabetes or diabetes in pregnancy. So talking about complications of diabetes in pregnancy, it's actually important to understand this part because to women in pregnancy, they tell them their sugar is high, they feel absolutely normal. They don't have any reason to want to do anything. Why should they take your dietary changes? Why should they take your tablets? Why should they take your injections? Part of the things you need to use to, I won't say motivate, but make sure they understand the implications of the issue. We have to understand the complications. Why do we treat diabetes in pregnancy? Because go to the complications. So there are maternal complications, which I will discuss just now. And then, of course, there are complications for the fetals. So the maternal complication, of course, there's increased risk for infections, hypoglycemia, increased chance of infections in the body. And of course, we know that infections can worsen pregnancy outcomes, both simple things like UTI, soft tissue infection, etc. Depending on the extent of the hypoglycemia. Also, we do know that diabetes or hypoglycemia in pregnancy increases the chance of having hypertension in pregnancy and also increases chances of having preeclampsia. So that is also important. And of course, people who have diabetes in pregnancy are more likely to have preterm labor. So they're more likely to have premature babies. They're more likely to have admitted later in pregnancy. There was a study that we did in Living Hospital maybe a couple of years ago that we looked at A1C and pregnancy outcomes. And part of the pregnancy outcomes we looked at was preterm labor and requiring admission in pregnancy. So these are some of the complications in the mother. Of course, we have traditional complications of diabetes like DKA, which is well known to happen in pregnancy. I think in the last 2 years, I've seen about maybe 3 or 4 DKAs in pregnancy. At least two of them were clear-cut GDM, as they didn't have diabetes predating pregnancy. So you can have DKA in pregnancy, and we should not forget that phenomenon of the so-called euglycemic decay. That is, decay can happen even when the sugar is not superbly elevated. Okay, so we should watch out for that. And of course, we know that people who have diabetes in pregnancy, particularly diabetes of predated pregnancy, they are prone to having vascular complications in pregnancy. Now, anybody with diabetes can have vascular complications at any time, but it can happen to be in pregnancy. But particularly, we know that retinopathy is known to worsen in pregnancy. People who have pre-existing diabetes that want to get pregnant should actually have their eyes checked, ideally, before they get pregnant. Apart from that, we also do know that the chance of having operative delivery is actually much higher. We said that earlier that in a series, out of all the patients that had CS in the UK audits, about 67% of them were related to diabetes. So the chance of someone requiring operative delivery is actually way higher for many reasons. The shoulder dystocia issue is there, the macrosomia is there, etc. So those are things. And of course, chance of genital tract injuries is there because, of course, the person is delivering a large baby or the person is having obstruction during delivery, which is Dr. Nichols' thing. So that is there. Of course, the chance of postpartum hemorrhages. Why are they more likely to have postpartum hemorrhage?
Yes, several factors. First and foremost, if a patient ends up having polyhydramnios, so there is this overdistension of the uterus, and then an overdistended uterus is a risk factor for uterine atony, and uterine atony increases the risk of postpartum hemorrhage. Also, a macrosomic fetus. The macrosomic fetus also tends to overdistend the uterus, and this also predisposes to postpartum hemorrhage. Now, very importantly as well, if there's need for like a woman that, okay, fine, she's been, like there's this patient, we did a scan in our center and the scan showed that the fetal weight was 4.3. Of course, you need to also counsel them that scans at the tail end of pregnancy has a range of error, 0.5 to 0. Plus or minus. And she held on to that 0.5 plus or minus because she really wanted to have vaginal delivery. And the main decision maker was her mom. And the mom said, no, my daughter, all my children were very, very big, so we are having vaginal delivery. And so we prepared ourselves for to take the shoulder dystocia because we knew it would happen. And it happened. We had to do some manipulation, and that's exactly what leads to the genital tract injury. So you should also be ready for that as well. And of course, when there's bleeding from the genital tract, that's part of the postpartum hemorrhage.
Absolutely.
So that's really part of it. Then another thing, also nephropathies. Especially for especially the type 1 and type 2.
Absolutely, absolutely. The slightly covering thing for that is just that many patients who have existing nephropathy, when people have nephropathy, their chance of getting pregnant is slightly reduced. But the ones that get pregnant, it's likely going to get worse in pregnancy, unfortunately. And of course, we know that for the GDMs, there's a long-term risk of type 2 DM. So a good factor, more than half of people who have GDM will actually have type 2 DM later on. So that risk is also there. And people who are lucky enough to recognize it during GDM, at least if they do lifestyle modifications and things like that, they may be able to delay the onset of type 2 DM later on along the line. So talking about the fetal complications, what are the fetal and neonatal complications?
So the fetal and neonatal complications, for the fetal complications, we divide them into trimesters. Of course, like the first trimester we spoke extensively about, due to the hyperinsulinemia.
Absolutely.
You could have congenital malformation.
Yes.
They could also predispose to, of course, increased rate of spontaneous abortion, etc. And then, of course, there's increased rate as well of in the first trimester and second trimester of preterm delivery for the various factors we've also spoken about. Then also with monitoring, we could also pick up very early enough. We could pick up macrosomia, fetal macrosomia. But of note is that due to the vasculopathies, we spoke about the issue of polycythemia. And polycythemia leads to hyperviscosity.
Absolutely.
And then with hyperviscosity, there's vascular surging and all that, and it affects some of the organs of the baby. And so some subsets usually have intrauterine growth restriction. And these are some of the complications. Then, of course, unexplained intrauterine fetal death, also unexplained stillbirth, usually 36 weeks thereabout. So that also even tailors our management. So most mothers want to deliver them after 38 completed weeks or 39 weeks. So we are very, very careful about that. Now, if for the neonatal period, we've talked about the birth injuries. We've explained the mechanism of all these birth injuries. Absolutely. Of course, when you're taking a shoulder dystocia delivery, apart from absolute extensive counseling of the patient, because when some of the manipulations can even lead to fractures. Fracture. Some of them could lead to palsy, etc. So you have to really counsel the patient and, of course, the decision maker as well. So these are some of the complications. Then for the neonatal complications, of course, we have all those electrolyte imbalance, the hypomagnesemia. They also hyperinsulinemia due to fouling and polycythemia. Absolutely. The cascade just goes around. And then hypoglycemia, which is really, really troublesome. In fact, we are always disturbing you, after we take delivery of most of our women, of course. So we have to monitor them very, very closely too. And then there are some other complications, so of course we'll be talking about as we go along.
Okay, so it's important to know that, and apart from that, like we said earlier, that actually the child of the mother who had diabetes in pregnancy, particularly GDM, is actually at high risk of childhood obesity, type 2 DM in the child himself later on, just because of some of the changes that happen in pregnancy. And of course, even cognitive impairment, cardiomyopathy, some people have described attention deficit hypercognitive disorder being more common in children of mother that had diabetes in pregnancy. So it's important for us to know all of that as complications of this. So I mean, we could go on and on about this, but we need to cut things short a bit. And now we'll just go to how to establish a diagnosis of diabetes in pregnancy or gestational DM, as the case may be. So, Dr. Nico, what are the main considerations when we are trying to make a diagnosis of gestational diabetes mellitus?
Yeah, so there's been a lot of consensus on this. Prior to now, the definition has been refined based on all these consensus, and of course, this cutoff point has also been redefined based on the following points. Number one, are we defining it based on the fetal outcome, the pregnancy outcome, or the maternal, yes, outcome during pregnancy? And that's why, if you look closely, there's been so much
debate.
Yes, debate on who should you screen. Should you screen all women that come into your clinic? That is not cost effective, especially in our in middle income countries. Should we just screen those who have shown one fallen into the risk group?
Absolutely.
So that has been a consensus. Who should we screen? Another thing is that how should we screen? So some of these bodies that we're going to highlight, they've spoken about we should screen, do a one-stop screening. That's one-stop check. 75% at
75 grams.
Yes, 75 grams at 24 to 28 weeks. Will that suffice? Or we should do the OGTT test. And of course, that test is actually called the oral glucose challenge test. Why the OGTT test? We do it over 2 hours, and then we take the values of the fasting, and then the 2 hours, very importantly, based on their check their threshold. Now, another thing that they have talked about is that how often should we screen? So for the oral glucose tolerance test, we have the 0 hour, 1 hour, 2 hours that we use for diagnosis. Yes. However, there's a 0 hour, 1 hour, and 3 hours. Absolutely. So really, the consensus has been you get your own cutoff threshold that works for your own women. You, of course, carrying out evidence-based study, and then you propagate it in that line. But for us in Limi Hospital, we'll be using
the IAD PSG criteria.
Yes.
Before we go into that, also what you talk about, how often should we screen? So some places, or for some kind of categories of patients, you screen very early in pregnancy, even on the first contacts. Some people don't believe in that and believe that you should just wait for that 24 to 28 weeks and do your OGTT. Each of all these approaches have their pros and cons. Some approaches will help you to pick more people, but at the expense of so many resources and having so many patients having to drink.
And that can be really unpleasant.
Yeah, it can be really unpleasant. And many women will actually feel that you're just putting them through unnecessary stress. You can't be checking these kind of things in everyone. But the major implication of the recently lowered cutoff is what we said earlier about that you are likely going to pick many more women. Many more women are actually going to have the diagnostic level without them needing any serious treatment per se, apart from some serious changes in their diets, which is often enough to control glycemia in these women. So I think we just compare some of these categories now, some of these criteria now, and then I'm not sure what we use in various centers, but in our center we often use mostly the high AD PSG criteria. So yes, we have these criteria here, and again, many of them are the OGTT, the high AD PSG, which I think is one that is probably most widely used in the world, apart from the US possibly. So the person takes a 75 grams, does a 75 grams of OGTT, which will be ideally after a period of 8 to 14 hours of fasting. Okay, and basically the patient is resting, and the patient takes the drink, and the sugar is checked for the IAD PSG. For the 75 grams test, basically, sugar is checked before the drink, that's fasting, 1 hour and 2 hours. Okay, and for the high AD PSG, once any of the parameters is abnormal and the test was properly done, you can state that the person actually has gestational diabetes. And I mean, the only major other question we have is that how many patients do we want to do this in? Are we doing it in all the patients, or are we doing it in some patients? Okay, so that's a big and a very valid question. I'm looking for the highlights. Okay, I'll just put spotlight. Okay, so that's the IAD PSG. Of course, we have the traditional Carpenter and Houston criteria, which is very similar to the NDDG, that's the US. I can't remember the full meaning now, but it's the diabetes group.
Yes.
Okay, they're very
we have a lot of groups.
Absolutely.
Even in Austria to Australia.
That's one of the problems we have with making the diagnosis of this GDM. Actually, there are a lot of bodies and they do different things in different places, which is quite concerning. But I think we are coming closer. We're having more and more consensus these days and division compared to what we had before. Okay, so for the cardinal and consensus criteria, we should notice that the glucose load is higher. Okay, and therefore by definition the cutoffs are higher. So the fasting cutoff is this. 1 hour is this, and the 2 hour is this, and of course there's a 3 hour for the 100 grams glucose load. And of course the NICE UK guideline is the fasting is more lenient, whereas the 2 hour is more stringent. They don't typically check the glucose at 1 hour, but once you meet any of these, either 5.6 fasting, either the figure and above, or 7.8 post meal, then you can make the diagnosis of the gestational diabetes. The American Diabetes Association supports that you can use any of these first 2 criteria. You can use either of the IED-PSG or the capital and percent criteria. And so basically that is that. In addition to that, I also want to add that for the term impaired glucose tolerance or impaired fasting glucose is not useful in pregnancy. Anybody that has any of those is either GDM or diabetes in pregnancy. So just to note that. And if someone was having impaired glucose tolerance and the person becomes pregnant today, the person already has diabetes in pregnancy because the thresholds are lower in pregnancy, and that's because of the implications for both the mother and the baby. So talking about the evaluation now, how should this patient be evaluated?
Yeah, so basically she comes in for antenatal visits, and then there are some things you need to do. Of course, after taking a history to pick out some factors risk factors that you get from the history, which we've already highlighted, and then of course doing an examination and of course sending her for some investigation.
Now talking about patients who have diabetes before getting pregnant.
Yeah.
Okay, so someone comes, that's pre-gestational DM, someone comes to clinic, says I have diabetes and I found out I'm pregnant.
Yes.
I see that a lot because I have a lot of diabetes patients.
Correct.
So if you're evaluating such patient, what things should we focus on?
Yes, very importantly, number 1, from your history, you need to focus on how her control has been.
Absolutely.
So how has this control been and what drugs is she on?
Absolutely.
Because really, it's just that in our environment, we don't have a pre-conceptional clinic before you get to antenatal clinic.
Absolutely.
So this is the point where you now start trying to, of course, a multidisciplinary team approach.
Absolutely.
Involve your endocrinologist and the drugs that are known not to be acceptable in pregnancy beneficial, then you now exchange them for the ones that have been shown to be of use in pregnancy.
Absolutely.
Of importance as well is to know how well she has been controlled. You can do a glycated hemoglobin. Absolutely. So that you can give us like a picture of the last 12 months, some people say
the last 3 months, yeah.
So
and 3 months. 3 months. And then we should also be aware of how to interpret A1C in pregnancy is different, but we'll talk about that along the line.
As well. Yes. So apart from doing that, of course, her urinalysis as well, and then of course you now book her for antenatal and then follow her based on the predetermined intervals.
Absolutely.
So those 3 things are very, very important. However,
so for patients with gestational diabetes, part of the things we want to do in the history is actually to rule out historically whether this person has actually likely had diabetes before pregnancy. Yes. Sometimes there are things that just give it away and you know that this person has actually had diabetes. So for example, people already having symptoms of neuropathy before pregnancy, people already having some blood vision or recurrent infection or polyuria before pregnancy, you will suspect that kind of person actually likely has pre-gestational DM. Of course, you can't state it categorically if you don't have data, that's blood test that says that the person has diabetes before pregnancy. So that's important. And for people who have GDM as well, we want to find out whether there's been GDM in previous pregnancy, have been on sugar tests before. In a cosmopolitan area like Abuja, people actually do sugar tests all the time. And some people think some numbers are abnormal, but if you just I did a fasting 2 years ago, it was 8.0 millimoles per liter, and they just told me to watch my sugar. You know that this person likely has had DM before. Okay. And then if you are picking GDM in mid-trimester, you need to ask them whether they actually did a sugar test in first trimester. Some people have done, and if you had it normal at that time, it reassures you that you are actually likely dealing with GDM. And it's important to distinguish between the two, like Dr. Nicole said earlier, that the chances of congenital anomalies and early pregnancy loss is actually much higher with pre-gestational compared to GDM.
Yes, because of the level of hyperglycemia.
Absolutely.
So, yes,
Absolutely.
and the timing of the hyperglycemia based on the development of the fetus.
Absolutely. So the other things that we need to look out for when we are assessing these patients, we want to assess for other cardiovascular risk factors, their hypertension. We want to look out for retinopathy and kidney disease, like we earlier mentioned.
Yes.
And then, of course, you need to know the pre-pregnancy weight of this person.
Yes.
The pre-pregnancy weight tells you how much obesity is there, and just helps you to really know, of course. And of course, if you're talking about the pregnancy appropriate weight gain that we talked about earlier, you need to know where they were coming from and compare to their current weight to know whether they've gained too much weight. Don't forget that a lot of factors make it's normal to gain weight in pregnancy, first of all, but a lot of factors can make some people gain too much weight. Apart from the consequence of excessive cravings and other things that happen in pregnancy, then people tend to reduce physical activity in pregnancy, which is normal. Okay, but those things can make some people prone to gaining excessive weight, especially if they're prone to being obese before. So then we want to find out about their previous pregnancy history, whether they've had bad pregnancy outcomes before. Those are things that should alert us and make us. There's a woman I'm currently still managing now, and every time she sees me, she actually really pleads with me again that I should make sure we're doing everything we should be doing, because she has had 2 bad pregnancy outcomes before, and then of course she has diabetes. She has pre-gestational diabetes actually, and she just wants everything to be done to make this baby normal. She always. She's already pregnant. She's in her second. She's close to 30 weeks now. She keeps telling me even that if I think she needs to travel outside the country to get something done, I should tell her. But I reassure her that we're doing all the right things. So it's important to take a dietary history as well. And people's diet often change in pregnancy. Pregnancy, apart from the cravings, people feel they deserve a treat in pregnancy because they're pregnant for Christ's sake. So, but we should take a dietary history, because if you're going to do dietary modification for someone, you actually have to start from where they are currently, what they're doing currently in terms of their diet, so that you can build on that or modify that to help them with their treatment.
Yeah, and in addition, there stated calorie intake for pregnancy, which would help mitigate excessive weight gain in pregnancy. So this would also be incorporated into our consultation as we manage her.
Absolutely. So apart from these things we mentioned, which other biochemical evaluation is appropriate for someone that is
biochemical? We can talk about, of course, the electrolyte urea and creatinine. We talked about the nephropathies that could also occur. So we should at least have a baseline on which to build up our management from. Then also the serum calcium and vitamin D, they are very important because there's this electrolytemia due to the hyperinsulinemia. So this is very important as well. Urinalysis, we emphasized it. If there is persistent glycosuria, bearing in mind that renal threshold is usually reduced for glucose in pregnancy. If it becomes persistent or it becomes at least at a particular level, some people say 2+6 based on lipstick. Then you now know you have to.
And it's important to do a fundoscopy for patients in pregnancy.
Yes.
Retinopathy is actually much likely to worsen in pregnancy. And we should not forget that when we are controlling glycemia aggressively, retinopathy actually has a chance to slightly worsen. And there's a lady I had that the first time she came here, the reason why she came was actually that because she has had diabetes before, she got pregnant, and then she had vitreous hemorrhage.
Yes,
she was taking care of the vitreous hemorrhage elsewhere anyway, but we had to manage the glycemia better. And so you just have it in mind that retinopathy is known to worsen in pregnancy, and that if someone with diabetes is actually planning to get pregnant, part of the things you should ask them to do as part of the conception care is to assess for retinopathy. So before we go into management, that's something.
Yeah, very important, and that's why even though we say meticulous glucose control, we shouldn't be aggressive in the glucose control.
Absolutely.
So it's very important. And then of course we also need to make sure that the folic acid is well taken, because it helps to reduce the incidence of
neural tube defects.
Neural tube defects in these women.
Thank you, Dr. Nicole. So before we go to the management proper now, which hopefully we'll talk a bit about, I'll just talk a little bit about the role of A1C in the treatment of diabetes and pregnancy, so to say. We mentioned earlier that before someone with diabetes get pregnant, it's important to pursue an A1C of less than 6.5%. because we know that the more normal the A1C is, the more better the pregnancy outcome is. So we're talking about less miscarriages, less congenital anomalies, less complications basically. So we want the A1C to be down. So that holds true, particularly for pre-gestational diabetes. But we should put in mind that once a woman becomes pregnant, A1C is actually slightly lower. A1C is slightly lower for several reasons. One of the main reasons why it's slightly lower, number one, is actually because of the increased red cell turnover, because of the anemia, and because of the hemodilution that happens in pregnancy. So A1C is usually, I'm not sure what percentage I'll put to it, but it's just about 0.5 to 1 lower than it should be in it. So if someone, even a normal person, gets pregnant today, in a month or 2 months, if you take the A1C, it will have dropped a little bit. I should put that in mind when we're trying to interpret A1Cs in pregnancy. So putting that in mind, the target A1C for a pregnant woman is around 6.0, but I would still say that it's often tricky to interpret A1C in pregnancy. But apart from having that target, one of the key roles is that number one is that if you're diagnosing someone with diabetes in pregnancy for the first time, particularly if you're making a diagnosis in the first trimester, even early second trimester, if the A1C is quite high, it's actually more likely that the person is having pre-gestational diabetes that you're just picking at that time. Then secondly, of course, you can use it to monitor control, because we know that if the A1C is rising in pregnancy, you're not getting control, there's glycemic issues, and that has been well correlated with pregnancy outcomes, which we have some studies on that in the hospital as well. So basically, the summary of that, particularly because the A1C is not as reliable as you want it to be in pregnancy, is not the primary modality of monitoring glycemia in pregnancy. Its role is at best as an adjunct for glycemic monitoring, but it's also very important. It's also very important, and it guides some of the changes we make. So I think that's the summary of the role of HbA1c in pregnancy and its limitations. So talking management now, part of the meat of the matter. How should we approach a patient who has gestational diabetes? Yes. Before we go to the management, I think we'll just take one of our polls. I think we've already answered, we've talked about this already, but I'll encourage our audience now just to participate in the poll. I'm going to launch a poll now. I'm just testing one of the common themes around gestational diabetes. So we have this question now, it should be showing on your screen at this time. A 28-year-old pregnant woman was found to have 2+ glycosuria on a routine urinalysis, and an OGTT was done. Okay, but this question is asking now, which of the following is not a risk factor for GDM? Which of the following is not a risk factor for GDM? I'm hoping that we all get it. I think it's fairly straightforward. We talked about this a bit. Which of the following is not NOT, a risk factor for GDM? Say that again. I think we'll probably share the second poll after this as well. I think we'll just do this for a few more seconds. Thank you for participating. Which of the following is not a risk factor for gestational diabetes? Okay, thank you very much for participating. The vast majority of people got the answer very correctly. Hypothyroidism is the most well-taken answer, and that's the correct answer. So hypothyroidism is not really a risk factor for GDM. Previous GDM is a risk factor, obesity is a risk factor, previous IUFD is a risk factor. In fact, previous part of obstetric outcome, generally speaking, can be considered as a risk factor. So thank you for participating in that. I think we'll do one more poll. Okay, so I think we'll leave the other polls until just a little bit along the presentation. So back to you, Dr. Nico. So when we're taking care of a patient with gestational diabetes, what are the things you should put in mind? What are the things that should guide our thoughts?
Very importantly, the outcome will really determined on the group of people that manage this patient. So it's a multidisciplinary team approach that we should employ when we're managing them. Like we highlighted all the complications, these different specialties will help to pick this up at the right time, and then intervention can be done. So this will include of course, the obstetrician, the endocrinologist, even the diabetic nurse, the dietitian, the ophthalmologist, depending on if she's had diabetes before pregnancy, etc. And then, of course, education is the bedrock for this. Education not only helps to counsel the patient on the outlook of the pregnancy and then how involved she should be, it also helps to incorporate a healthy lifestyle. Because really, those that have the gestational diabetes, which can be controlled with dietary modification, if they are well educated, they can really achieve good pregnancy outcomes. So, of course, education on the safe exercises that should be done. In pregnancy, for you to institute exercise in pregnancy, you have to take a step back to pre-pregnancy lifestyle. Has she been really athletic? Has she been adopted more of a sedentary lifestyle? So that you can curtail the safe kind of exercise during pregnancy, which helps out on the long run. Then, of course, notably, her medications. For women that haven't had the opportunity to have preconceptional care, we can now review all the medications she's in, incorporate the endocrinologist, and then decide on the best medication she should be on, or no medication at all based on the indication. And of course, as part of the principle, we've talked about the monitoring, which we cannot overemphasize, and follow-up and long-term care.
I think that just totally summarizes it. So from the obstetric point of view, I know that there's some things that you give priority, generally speaking, to as an overview now when we're talking about caring for these kind of patients. Can you highlight those things for us?
Yes, in terms of overview, in terms of drugs, of course, we need to ensure she's taking her folic acid. Apart from those other hypoglycemic, if she has been started on that, or of course, insulin if she falls into the indication for those, and if it's indicated in the particular cases. Then, of course, the antenatal care visits. In order for you to pick up these complications as your core, we usually term them high-risk patients. Yes, some people feel offended when they hear that, but it just gives us a prompting that the monitoring needs to be more frequent. Usually, it's stated that you do it 2 weekly until 32 weeks, and then weekly thereafter. However, this is not really feasible in our low-income country or middle-income country, so we'll try to fashion it based on our domicile, our practice. So apart from that, we are also monitoring with those biochemical parameters we spoke about. We've done the hemoglobin, glycated hemoglobin, we do the urinalysis, and then those that qualify for fundoscopy, we do that as well. Of course, all these help to pick up all the complications. And of course, antenatal fetal surveillance. This cannot be overemphasized. The simple thing of symphysiofundal height can help pick out a lot of cases of either fetal macrosomia or intrauterine fetal
retardation.
Yes, growth restriction.
Absolutely.
Yes.
Absolutely. So apart from that, of course, the antenatal care, the delivery, postpartum care, all has to be properly planned.
Yes.
Okay, and I know that you're going to still tell us something about breastfeeding and contraception in these women. You cannot finish take care of someone that had diabetes in pregnancy and then you don't discuss contraception with the patient. I think that would be very inappropriate. From a medical point of view, the nutrition therapy, Dr. Nicole has spoken quite a bit about that. And like we said, it's actually best the clinic is a joint clinic where that's the best way to apply all those kind of clinics, where the dietitian is in that room, the obstetrician, everyone can actually be in the same room and see the patients. So that actually gives the patients a richer experience rather than go and see this person in this place, see that person in that place, and everything is just a little bit disjointed, even though multiple specialties are seeing the patients. So that is there. She's talked a bit about physical activity and lifestyle changes as well. Of course, the glucose needs to be monitoring and the patients need to understand the targets, but the doctor needs to understand the targets as well. Of course, we should know when we need to start insulin, when we need to escalate the care. Overall, the care has to be integrated, and the patient has to be at the center of the care. The patient should understand what we are doing, and the patient has to understand his or her role in the care of that issue. Of course, perinatal management is a big deal, and at the time where someone has diabetes in pregnancy delivery, a lot of care has to be taken to get the best outcome for both the mother and both the child. And I think that is actually like the crown of everything that you guys have been doing over the past several months. Of course, throughout pregnancy, like you rightly said, follow-up should actually be 1 to 2 weekly. And I actually try to maintain that for many of the patients. When it's difficult, some of the follow-ups, some of the follow-up can be by phone, or as much as possible, particularly for those on insulin. The follow-up has to be quite frequent. And the truth is that things can actually change rapidly in patients with diabetes. The glucose can go up, the woman can start feeling somehow. In fact, I've had some before, some nasty experience I don't really wish to talk about, but I've had patients that you saw maybe 3 weeks ago, and then next thing I just experienced that IUFD, and you wonder what went wrong. So talking about the preconception care of someone with diabetes. So someone has diabetes, let's say has had GDM before, but someone with diabetes now, what are the things we should pay attention to during the preconception care for the couple?
Yeah, so we won't overemphasize this fact. First and foremost, her medications.
Yeah.
What's she on? Is she on control based on diet, or
Yeah.
she's on control based on oral hypoglycemics or insulin? Now, for those that are indicated in pregnancy, allowed, beneficial in pregnancy, we allow that to continue.
Absolutely.
Then we must make sure that she has a daily intake of folic acid, because this helps to reduce the amount of incidence of congenital malformation.
Absolutely.
Even if there is a setting in place to help to make it, to increase the prevalence of that. Then in addition to that, you have the opportunity to educate her on a good lifestyle, dietary modifications as well, balanced diet, appropriate carbs. You can calculate her calorie intake.
Even before pregnancy.
Yes, because really at that point, that's the best point to get them, and then get them early enough. Then apart from that, for preconceptional care, you want to also inform them that it will be important for them to book for antenatal appropriately as well, because that increases the outcome,
improves the outcome.
Improves the outcome for both the mother and the child.
I always like telling patients, to people with diabetes that are telling me that they're possibly planning to get pregnant, to be financially, emotionally, psychologically, even work ready for the pregnancy. Why? Because someone, particularly with gestational diabetes, is demanding. It's demanding. You have to be checking your sugars more than 4 times a day. Sometimes you need to be coming to clinic a bit more frequently, apart from the normal regular demands of pregnancy. So that means it's not the time that parents will now say, I can't afford insulin anymore, I can't afford to come to the hospital or office or work is like this. So if you have diabetes and you're planning pregnancy, you actually need to take time to plan it, and you're ready for it by the time it's coming.
In fact, at that stage, that's when we even tell them, sorry, we can't allow you to get pregnant, and put them on contraception. Because if we have not achieved euglycemia at that point preconceptionally, then we need to hold on until.
Absolutely, and that reminds us that the A1C should be kept at least less than 6.5 for at least 3 months before conception.
3 months.
And then the glucose should be hardly normal. That's what the literature says actually. To achieve normal glycemia. And that's talking about a fasting that is less than 100. Postprandial less than 140. That's for someone that is planning to get pregnant. Okay, and actually, it's always a good idea to switch to pregnancy-compatible medications at this time. Sadly, I've heard of stories of people who were taking some certain anti-diabetic agents I won't really mention, and even antihypertensive. Person was on ARVs and all. So just standard cardiovascular cocktail. I just came to tell me that I got pregnant 2 months ago, but I lost the pregnancy 6 weeks after. I put my hand on my head. You didn't tell us we were trying to get pregnant now. We should have stopped this drug, we should have stopped that drug. But my mind now pricked me after, like, did I actually discuss pregnancy with this patient? Did I tell the person that if you are going to get pregnant, let us know, so that if you are planning to get pregnant, or if you are not on any effective contraception, we would have to stop this drug, change it to that one. So those are conversations we need to have with our patients. Okay, and of course, some patients is actually not just healthy for them to get pregnant. Maybe an individual specialist decision on those ones. So if you have such patients, we need to tell them what the impact of pregnancy can be. That okay, you have this, you have that. Pregnancy can do this like this. Are you sure you're ready for that? Okay. And of course, I think I've talked about the high and renal screen earlier. So what kind of, you've talked a bit about the education. So I think we won't belabor that education as well at all again now. But the education should be done by either the doctor or preferably by the diabetes educator. And of course, we want the patient to actually understand, we are beyond preconception care now. We're talking about a patient that comes to clinic now that's been diagnosed with either GDM or pre-gestational diabetes. You need to make the patient understand the diagnosis of the GDM, the implications, and why they need to participate in the care. And we need to get their buy-in. We need to empower the patients to understand everything, basically, everything, why they're feeling like this, what their sugar should be, how to even interpret their glucose trend themselves. And of course, at every visit where the patient comes to clinic, we try to educate them at each of those visits. We look at their charts together, the glucose they are monitoring at home. We help them make sense out of it. Why did this fasting go up on this day? Why did this one go like this? Why was this one go? We help them relate it to their day-to-day activities, talking about their meals and level of physical activity, such that the patients learn from every experience and the patient is more empowered to progress with that pregnancy. So the role of patient education cannot be overemphasized, actually. It cannot be overemphasized. So in terms of the diet, I know we've talked about that a lot, and I think we won't talk about that so much again. But because the postprandial excursion is a dominant abnormality in GDM, and that's why you should not rely on fasting alone to diagnose it. You need to see what the sugar looks like after a glucose load. It's quite responsive to dietary changes and lifestyle changes. And that's why it's not surprising that more than 80% of patients with GDM will not require any pharmaceutical at all. It's just diet and lifestyle changes and glucose normalizes. Okay, so caloric intake should be limited. Should be limited, and that's why the help of a dietitian is invaluable. And of course, we don't want them to gain too much weight. They should just gain the right amount of weight in pregnancy, which is trimester specific, and it's also specific to the body weight category of the person, whether underweight or overweight, like we said earlier. Exercise is also important. What kind of exercise is appropriate for pregnancy, Dr. Nicole?
Yeah, so the categories of appropriate exercise will depend on how athletic these patients are when they come into our clinic. So we want to ask them during the education, have you been engaging in exercises? Do you go to the gym? And then she pinpoints exactly what she does. And then, of course, we try to tailor it to her present. So for those that really lifestyle, we can adopt strolling for with time, and then subsequently rights, frequently we always tell to feel pain. Now another thing is that close to delivery, not really at the first, second trimester, there's this exercise goal that helps as well, because not all patients that are diabetic or have gestational diabetes qualify for an operative delivery cesarean section. So there are some exercises that they can do. You sit on this big ball and then go, you sit on it and get up, you sit on it several times, and that helps. Now,
just sitting down and getting up.
Oh yes, that helps
beautiful.
a lot. Close to the third delivery.
And I'm sure many of them would like that actually, since they don't have to leave their house.
Yeah, they don't have to leave their houses. Now, there's another simple dancing. Dancing is a form of exercise because you incorporate all the aerobics, the cardio, or even climbing up the stairs gently if you don't have risk factors for preterm contractions. So these are part of the things they can engage in. Another beautiful thing apart from say for this COVID period is swimming. Yeah. Swimming, you exercise all groups of muscle, but then you don't end up. Yeah, so
I'm sure Dr. Nicole likes swimming. If I recommend swimming to any of my patients in pregnancy, they'll freak out perhaps. But
it's a good form of exercise.
So that's awesome. And particularly exercise, particularly after meals, is useful in GDM because it helps them mop up that postprandial glycemia that is a major problem. So I'll just talk about some of these medical parts first, and then Dr. Nicole will give us insights about the antenatal and other obstetric care. So the pharmacotherapy, basically, as I said just now, is that the vast majority of patients with gestational diabetes actually you'll be able to manage on just diets and lifestyle changes alone without requiring for pharmaceuticals. Okay, so usually, of course, you give them time. I've mentioned earlier that their clinic appointments typically should be about every 2 weeks. Sometimes you need to make contact with patients earlier, even as early as 1 week. And NICE UK recommend 1 to 2 weekly contacts with the healthcare providers. Now, if after the first 2 weeks, you're not meeting your glycemic targets, and glycemic targets are okay, we're going to get to that. I'll indicate that later. So if you're not meeting your glycemic targets, then usually you need to escalate the care. Escalating the care meaning starting some form of pharmaceuticals. Okay, so you don't want to drag for too long. And it's very common in pregnancy that patients will actually try to connive with you and ask you to wait. That's because they did it, they didn't do that, and then you just leave the glycemia lingering until you now hear that the patient has polyagraminosis or something is happening, and then you feel bad for having not taken charge earlier along the course. And of course, if there's overt hyperglycemia ab initio, that is, if you're getting numbers that are quite high, usually we say that by the time you're getting a fasting that is getting above 120 or 125, fasting or postprandial is getting beyond 160, is quite unlikely that diet and lifestyle alone would work. Or you have a A1C that is outrageous, that is already above 6.5. So in those kind of cases, please, we should start pharmaceuticals early without waiting for so long. Otherwise, we are going to leave the fetus exposed to hyperglycemia for longer. And don't forget that when we're starting medications, insulin is the first line for vast majority of patients. And we can use either a basal bolus regimen, in which you use a prandial insulin before meals, either soluble insulin or preferably the insulin analogs like Lispro and Aspart or the Gludec. Use that before meals and use the basal insulin at bedtime. Of course, the basal insulin that is preferred, Disame has a bit of more data in pregnancy than glargine, but you can use your good old MPH as well, which is human insulin and is obviously safe in pregnancy. We can also use a twice daily premixed insulin, again, preferably the analogs, because they have this profile that will better control postprandial glycemia. So they have to start acting faster, they peak earlier, and of course they stop acting faster as well. So you can either use either of those two regimens. The first regimen, the basal bolus regimen, will give us a finer control and a more flexible control, but of course at the expense of more injections per day. Most patients will usually prefer the twice daily premixed insulin regimen. When you have the facilities available, the CSI high, that's a continuous subcutaneous insulin infusion using an infusion pump, using an insulin pump, can be helpful in some patients, particularly in patients in which it is difficult to get good glycemic control without having excessive hypoglycemia. Okay, so the CSI can be useful in some patients. Unfortunately, it's not really available in Nigeria and it's extremely expensive. The guest I helped source one in US recently is summing up to maybe over 3M in Nigerian currency to get the CSI high. So that can be a bit cumbersome, but some patients will actually benefit from that. And the initial dose is usually around this that is stated, so that we are talking about for a 70 kg man, you will be needing up to that. But usually it's better to start small and titrate based on the response. So basically that is the summary of the pharmacotherapy and starting the insulin. We should not forget it's important to start on dietary and lifestyle treatments alone. Or if within 2 weeks you're not getting enough response, and that's defined by the targets. I expect that at least 80% of the glucose reading should meet the targets. If that is not met, then we need to do something different, and that's by stepping up the treatment. But ab initio, if you have overt hyperglycemia, please don't wait for 2 weeks. I typically can give those patients SMBG, self-management of blood glucose, do for 2 to 3 days, look at the results, and then make a judgment on starting medications based on that. So apart from that, of course, there's the role of the oral agents, which is a bit controversial, I would say. Okay, so but metformin and glyburide, which is glumentamide, has been used to a variable extent in pregnancy. Metformin particularly, we have more safety data on it in recent years. and it's being used more and more as a first-line agent for dysglycemia that is not so gross. And it will work for a lot of patients actually. I know that in the UK, NICE UK recommend metformin as a first-line medication for diabetes in pregnancy or for gestational diabetes. And whereas in the US, is a general no, okay? In the BNF, metformin is classified as usable in pregnancy, whereas if you look at US data, they're quite reluctant to use metformin in pregnancy. Okay, but the advantage of metformin is the lower risk of hypoglycemia, less maternal weight gain. Of course, it's very convenient for the patient and more acceptable for many patients. But we should be aware that it crosses the placenta. And although it's not teratogenic, we don't have a lot of long-term data on, particularly on the offsprings. I don't think there's any data that is longer than 5 or 10 years on the offspring of people that were given metformin in pregnancy. So we should identify cases in which metformin can be safely used. Okay, but generally speaking, again, insulin is the first line for most patients. And I'll tell us again that metformin will not work for a lot of patients. That's the truth. Just because of the metformin is more effective in addressing fasting hyperglycemia than the postprandial hyperglycemia, generally speaking. Okay, so that will be the summary for the oral agent, which is metformin and glibenclamide. For the glibenclamide, I actually don't really have any much experience in using it. I've not used it for anybody before in pregnancy, and I don't think I would. So basically, those are the oral agents. Now, talking about monitoring, I tell people with diabetes that monitoring glycemia is actually one of the most difficult parts of managing diabetes in pregnancy. The most difficult part is the diet. That is, you are going to be having pregnancy cravings, and doctor has told you you should not eat this, you should not eat that, you should eat little this, you should eat little that, and you can't fulfill your cravings. But after that, monitoring is perhaps the next most difficult part, because fasting blood glucose alone is insufficient. The most prominent abnormalities we have in diabetes and pregnancy is actually the postprandial abnormalities, and you actually have to check it continuously. And that's why most people have to check at least daily 4-point glucose profile by doing a fasting 1 or 2 hours post most meals. Some guidelines support more of 1 hour, I do more of 2 hours. Okay, all guidelines support more of 2 hours. And whether 1 or 2 hours is when you're likely to peak depends on actually how complex your meal was. A more complex meal will peak later. A more simple meal is likely to peak earlier. But you want to catch the peak, and you want to know if the excursions is higher than what is recommended. While it's acceptable to do a less intense monitoring for people that are not on insulin therapy, the patient has to be monitored, and it cannot be fasting alone. In fact, the fasting is the least useful of the parameters, and that's why women will try to shy to. Treatment requirements often increases as the pregnancy progresses, because, as we said earlier, the amount of insulin resistance is greater in the second and third trimester, and we have to titrate insulin doses in people who are on insulin upwards till the targets are attained. So I've seen some people that are pregnant on insulin, and they were started on so-so dose and they remained on that dose, and their sugar is not controlled. So what's the point of using the insulin? So we should actually titrate the dose till the targets are attained. So I think that will summarize many of the medical components of the initial management. So what if we're looking at the antenatal clinic, if we're seeing a patient who is found to have GDM in the antenatal clinic, what are the key things that would put in mind and we want to address first?
Yes, the key things will include, of course, we've talked a great deal about the history.
Absolutely.
Now, investigations.
Yes, please.
So we'll talk about the urinalysis we need to do. We know the reason why. And then, of course, we want to know a baseline renal function.
Absolutely.
We want to know the baseline renal function. Okay. So for the first trimester, we incorporate a multidisciplinary approach prior to instituting all the investigations that we were just talking about. And this multidisciplinary approach, we have spoken about each subspecialties that we need to we need to know how she is the data. Remember the data usually when you pregnancy to do a data, and then of course Now, to find out if there are some complications, and this when all the investigations come in. Urinalysis, a full blood count, a urea electrolyte, we need to know a baseline for that.
Now, you talked about fetal surveillance earlier.
Yeah.
Why is that fetal surveillance? Why is it important, and when is it done?
Oh, it's very necessary, and it's a continuum. So it's done throughout pregnancy. So as part of the surveillance of the fetus, a dating scan falls into that fetal surveillance. Okay. Your daily continuous symphysiofundal height assessment is also an inexpensive way of doing fetal surveillance. Okay. Also, the Doppler, we are not in Limit Hospital, we have handheld Dopplers all around. So we can easily monitor the fetus based on how far gone she is in pregnancy, because at the earlier stage, you don't pick it on fetal using the handheld Doppler. And then, of course, we also do, that's based on your question on the antenatal fetal surveillance. We have the privilege also in Limit Hospital to do a detailed anatomy scan. Oh, yeah. It's really called an anomaly scan, but it's really unpleasant to the ear. So we call it detailed anatomy scan. And then where indicated, we can also do a fetal Doppler serially. What are we looking for in the fetal Doppler? Yes, for the fetal Doppler, we are looking at the pulsatility, resistivity index, indices, or the peak systolic symmetry of the umbilical artery Doppler. That's the first part. If those ones are normal, and of course we do the medial cerebral artery Doppler, and they are normal, we don't need to extend it. However, if these are abnormal, depending on the gestational age, you can go ahead and do the ductus venosus. And that one has a direct connection to the left side of the heart. So it gives us an idea of how long more we have. And it also helps to pick up all those fetuses that... Okay, so we are running out of time. What are the things that guide you on determining the mode of delivery for a patient and even the timing of delivery? You did mention earlier that you guys want to deliver them a little bit, I don't know, 38 weeks, 39 weeks. Why choosing that time? And then what will guide you in allowing it as continuous induced labor, or you tell the person that this has to be CS? Yes. Very importantly, so for those that are well controlled, we've picked up no complication. We want complications during the pregnancy. We want to deliver them at 38 completed weeks or 39 weeks. Because the reason for this is that the lung maturity is questionable due to the hyperinsulinemia. So really, we need to know that the hyperinsulinemia delays lung maturity. Yes, beautiful. So we really need to know how they'll be able to cope extrauterine in the extrauterine environment, and then prevent all these transient tachypnea of the newborn, etc. So we need to. That's why we stated that's 38 to 39 weeks. Now, not all patients really you should go for a cesarean delivery. I mean, a patient that has been well controlled, monitored, multidisciplinary approach, you've done your scans, everything is normal. At the end of the day, you do it's cardiotocographic monitoring, which is another way of antenatal fetal surveillance. You do that when it's indicated, and you find that it's really reassuring or reactive, depending on the stage of pregnancy. You can allow her to go into labor, especially if she comes in spontaneous labor. In fact, in an obstetric unit such as the one we have in Limit Hospital, we have our antenatal fetal surveillance there. CTG, we have a scan that we can easily access. We can even engage in induction of labor. The most important thing is that, of course, you have close fetal monitoring, so that whenever a form of complication takes place, you can easily access the theater for cesarean delivery. Now, for those that qualify for elective cesarean section, these are women that have been shown to have some complications. Fetal macrosomia. Fetal macrosomia really predisposes into those. Fetal macrosomia predisposes the fetus to having shoulder dystocia and other complications that we've talked about, genital tract injury, etc. Even fetal demise, if the skills to deliver such fetuses are not available. So we now book them for an elective cesarean section after adequate counseling. Now, for an elective cesarean section, has a better outcome than for a woman who has been monitored during intrapartum, that's during delivery, and then now qualifies for an emergency cesarean section.
So the outcomes of the emergency CS is not
usually not as good as the elective cesarean.
I would just also ask something now. Apart from some patients often think like, oh, once it's diabetes in pregnancy, I must be CS, and they try to run from this because of that. So you said that is not necessarily true.
No, it's not. So it's only if cesarean section is indicated, if there are obstetrics indication for cesarean section before we carry that out. Now there are some particular things we need to carry out during intrapartum monitoring of the fetus that will help to improve the outcome. So a patient's glycemic management is very important during labor. So you need to monitor her blood glucose because, of course.
Absolutely.
Yes.
I think I would just want to highlight that part that a lot of patients who have diabetes in pregnancy will actually require insulin during labor, especially if they go into labor. Why? Is because there's a lot of stress during labor. Stress hormones are there, and of course, those who try to push up the sugars, and of course, it increases the chance of them having hyperglycemia. I know that hyperglycemia, even during labor or during CS, worsens the outcome of the delivery process, one, and of course, increases the chance of having neonatal hypoglycemia. But that being said, most patients with GDM actually will not require any insulin at all peripatum, just monitoring. But whether or not the patient requires insulin, we need to be monitoring at least hourly, usually during CS or during labor. Some people do 2 hourly, but hourly is often safer. And again, we also do know that patients who require very little amount of insulin during pregnancy will probably not require insulin during labor. So, of course, a lot of things guide us, but I know that for most patients that have a total daily dose of maybe less than 25 or less than 30, will probably not require any insulin during labor. But if they require more than that, they probably will require. But don't forget that that's just gauging it from far. It's actually the ambient glycemia on the day of labor and during monitoring that will tell you whether a patient requires insulin or not. Basically, during labor, you want to keep the glucose less than 110 milligrams per DL. They want to keep it less than that, and once it's going higher than that, you need to start paying on some sort of insulin infusion. Like I stated, it's critical to have guidelines for managing diabetic women during labor and during surgery, and I think we have some of those. So it's important to have that and to follow it and to use it and continue to modify it routinely. It improves the outcomes for patients. I think you've told us about elective induction of labor or elective CS earlier.
Yes, and very importantly for those that have been on insulin, it's very important that their last dose should be denied before, both for those being induced and for those going for a surgical delivery.
Okay.
So it's very important we understand that. Then also in preparation for the next day event, we need to also carry out an electrolyte and urea assay so that we can ensure that the right amount, though there are different regimens, right?
Okay, but at least the right amount of constitution is made for the GKI if you're going to use a GKI infusion. So you mentioned importantly that the medication as the last dose of insulin should be on the night before, because usually, of course, if they're going to be induced, they can't. If you give insulin that morning, you may run into troubles. Particularly, of course, if they're doing CS that morning, the patient will be on MPO as well. So basically, the insulin should be skipped in the morning. The glucose is monitored. That's intrapartum management now, preferably hourly. The glucose should be monitored preferably hourly. And of course, if the glucose gets beyond the targets, and I mentioned earlier that you don't want it to be exceeding 110. If you have a glucose level above 110, then you should start the patient on some sort of insulin infusion. It's inappropriate to put the patient only on normal saline, particularly a patient in labor. Just put the patient on normal saline. The person is not really eating. The person can develop ketosis from that because you need carbohydrates and carbohydrate metabolism to actually go through that process of labor. So it's ideal to put that normal saline alternatively with something that contains dextrose like 4.3 or 5%, but it will inappropriate to just keep on normal saline alone because the person has diabetes. But so in people that require insulin infusion, you can either do a insulin infusion by an injection, by a syringe pump and plus a dextrose infusion, or you do what we call a GKI, that's a glucose potassium insulin infusion, and that will be based on the blood glucose strength. You should not forget that you're taking the glucose hourly, whether or not you need an insulin infusion. And of course, if you do need an insulin infusion, you continue to check the glucose hourly and you adjust the insulin based on the blood glucose strength to keep your sugars between 80 and 110 milligrams per dl. And in GDM, in classic GDM, as soon as the placenta is delivered, the glucose tends to crash and you need to stop the insulin infusion immediately and replace with a dextrose-containing infusion. Whereas in pre-gestational diabetes mellitus, oftentimes the need for insulin or at least something to control the glucose persists even after delivering the placenta. But of course, the insulin requirements is greatly going to reduce because many of the counter-regulatory hormones will be down at that time. Even after delivery, it's important to continue monitoring. Of course, the frequency of monitoring is still down, remains hourly for a while after delivery, then 4-hourly, and then depends on the numbers you get, we slowly tail down the frequency of monitoring.
And then, of course, immediately after delivery, if she had a vaginal delivery, it would be appropriate for her to have a meal, because this helps also to stabilize the blood glucose while you are still instituting 4-hourly monitoring.
Absolutely. Otherwise, they'll have a high risk of going into hypoglycemia. We've seen that a few times. Sometimes when the GKI was not fully clipped up, or the dose of the evening insulin they have the next day, particularly people that are using human insulin, is still lingering as at the time of delivery. So all those things can increase the chances of having a postpartum hypoglycemia in the mother, which is usually not nice. Okay, so we should not forget that the blood glucose should be monitored hourly in patients who are in labor or during CS for a person that has diabetes mellitus. In people that we have to do induction of labor for, what are the things that we put in mind for? What are the things that we do specifically?
So for induction of labor, of course, we want to improve our chances of having a successful vaginal delivery and to reduce the chance of prolonged labor. So number one, we need to, of course, try to ripen the cervix, especially if the cervix is unfavorable. So unfavorability has a scoring system, the Bishop score, and so we try to make sure it's favorable by passing some of this, by instituting some of these things. We can use a Foley's catheter. There are other things we can use, but for now, let's just focus on using the Foley's catheter because that's really less expensive, easily accessible. So usually it should be passed at 1800 hours the night before the induction. The night before the induction of labor. This increases the chances of ripening the cervix, making it more amenable to contraction and subsequently delivery. And it also reduces the chance of having an infection. It's a foreign body, and so you don't want to leave it in there for too long. So on the morning of the induction, after assessing her and carrying out some investigations, you still reassess the Bishop score. Because if the Bishop score becomes favorable, you will know you can commence your induction. Or if the cervical parameters attain active phase parameter, then of course you can just manage her in active phase labor. Then of course the monitoring of the baby. This cardiac tachograph is very important. At this stage, you don't need to trace all the time. You can just hook it on the woman, apply it onto the woman, and then monitor her subsequently. We've talked about the blood sugar test, and of course, you watch out for different complications. Now, how do you detect cephalopelvic disproportion? You're doing an indicated vaginal examination, and you notice in between two consecutive examinations, you will notice that the fetal head, the presenting part is not descending, and so the station remains the same. The cervical dilatation is not improving at all. So in between two examinations, the cervical dilatation remains the same. Then you now start to suspect. However, you can definitely say that there is some form of cephalopelvic disproportion when you have evidence of fetal-maternal squeeze vis-a-vis increasing caput or molding. So you need to watch out for that. And that's why in Limi Hospital, we have instituted pathographic monitoring of labor. And this helps to detect it. Anybody at a snapshot can just pick up the one piece of paper and look at it and say, oh, this is certainly CPD, you cancel the woman and then you prepare her for emergency cesarean section.
Okay, so that's basically the delivery part. And of course, we should remember that after delivery, we'll still need to take care of this woman. Thankfully, in GDM, that is the true GDM, most of them return to normal after delivery. In fact, within hours of delivery, the glucose normalizes. But of course, we should take care to confirm this 6 weeks post delivery. ideally by an OGTT test,
yes,
which we don't often do. But at least if we don't do an OGTT, at least you do a fasting and a 2 hours post meal. Okay, but ideally by an OGTT, many women will not agree to drink that stuff again. But if it's to reassure them that you can certify them now free of the GDM, it can encourage them to do the OGTT at that 6 weeks post delivery. We mentioned earlier that we should continue to monitor the blood glucose after delivery, and thankfully, many patients they had a glucometer in pregnancy. They were checking 4 times a day. They don't actually find it difficult to check from time to time after delivery to see that these numbers are actually now normal. But please put in mind, when we're monitoring these patients postpartum, we should know that the threshold for that we use to diagnose GDM and for the targets is not the one that you use once the mother has delivered. You go back to the non-pregnancy targets. So at that point, they have fasting of 95 is actually okay. It's not abnormal. If they have fasting of 97, it's actually okay. It's not abnormal, which will have been abnormal in pregnancy. And so basically that's that. And of course, these patients need to know that they have to be screened for life. Yes. It's lifelong. Patients don't like hearing that word lifelong, but the truth is that it's some sort of lifelong screening that a patient with gestational diabetes, because the risk of developing diabetes along their life course is actually way greater than 50%. The vast majority of people who are GDM will actually develop type 2 DM later. And of course, thankfully, we recommend that we should build on the lifestyle changes that they got used to in pregnancy. I have a lot of patients with diabetes that, I mean, they need a lot of sacrifices. They cut down the amount of rice they take to chocolate quantity, and they do all those kind of sacrifices. Of course, usually I console them, like telling them that don't worry, after the delivery, this will go back to normal, you can eat your rice. But they should not go back to where they're coming from. They should actually maintain some of the changes and those things to reduce their chance of developing diabetes down the line. What should we do for the baby? What needs to do for the baby after delivery?
Yeah, we want to watch out for symptoms of hyperinsulinemia, hypocalcemia, etc. So monitoring, and that's why we called as well. We continue pediatrician because they are actually opted just before delivery.
Absolutely.
Yes. So monitoring it, and then you notice any form of hypoglycemia, this is corrected, and then they are placed on maintenance. Of note is that we want to commence breastfeeding if indicated as soon as possible.
Absolutely.
So that helps to maintain euglycemia in the new units.
We need to round up now.
Okay.
We work in what does hypoglycemia, does it warrant admission of the baby, and does it warrant admission into the new? I know that this is more for the pediatric people to answer, but what would you say to that?
No, honestly, hypoglycemia may or may not warrant admission. Okay. We could even admit her by the mother's side. Mother, yes, and then before it's in the monitoring. You see, some hypoglycemic units, they end up achieving euglycemia following close monitoring, while others, they have erratic results. And that is when the pediatricians now decide they need closer monitoring.
And inside patients. Okay, should people who have diabetes in pregnancy, should they breastfeed or not? Can they transmit the sugar to their baby?
Oh, so very importantly, breastfeeding is even one of the recommended practices that we should learn to educate them on. It not only helps with neonatal survival, but it actually helps in weight loss of the mother, because the calories expended when you are lactating is actually more than what you
expend if you're not lactating.
Yes, and also the calorie intake is just boils down to the calorie intake. In lactation, you need a lot of calories. In pregnancy, the calorie is commensable. However, if you breastfeed and you do it at demand, which is what is recommended, calorie intake will be curtailed down for you. In addition to that, good habit, of course, because they are predisposed to infection. So good hygiene habits should also be educated to the mothers. And so that reduces the amount of infection that she may have. In addition to that, we also re-advise her to, is either we are cutting down the insulin or the hypoglycemics if it's a GDM patient, or we are reverting back to the pre-pregnancy dosage, and then you encourage her on that.
And before going back to for pre-gestational diabetes, we should know that the softener ureas and DP4 inhibitors should not be used in breastfeeding people because we don't have safety data on them. Some people have used some SU before, but many SUs, I think particularly Glubencamin, has been shown to be expressed significantly into breast milk and can cause hypoglycemia in the baby. So we should be aware of that. And metformin is excreted a bit into the breast milk, but it's not been found to show any harm to the babies yet. So I think basically we'll round up the presentation with that. Just the final things to mention here will be that there's a long-term follow-up. Patients like that should actually be should screen long-term. Some guidelines recommend checking every 1 to 3 years, but our practice here we actually recommend that they check every year, especially if the 6-week OGTT is normal. If it's not normal, then we'll make a diagnosis of either overt diabetes mellitus or impaired glucose tolerance or pre-diabetes. Okay, so we should screen them long-term, and we can utilize any of the normal screening parameters. We should remember that we should use pre-pregnancy values or normal diabetes screening values, not the GDM values when we are screening such patients later on along the line. And of course, I've mentioned earlier that we need to build up on the changes they made in pregnancy. Okay. About contraception, what would the advice be of family planning?
So this constitutes a very important aspect during the postnatal visits. Number one, a GDM patient, the increased number of times you go through pregnancy increases your risks because of all the aforementioned things. So we usually advise them to limit their family size. 2-3 children will suffice. Now, ideally, we don't want hormonal contraceptives. Now, this is indicated based on the medical eligibility criteria, but this is not the first option. You can advise them on bilateral tubal ligation if they've attained their family size, or even vasectomy for the men, which of course has reduced intake in our environment. Now, talking about some hormonals, we have seen that some hormonal contraception that are high in estrogen can actually increase the rate of poor glycemic control and the complications therefore. So that's why we have decided that fine, if you can get low estrogen containing contraceptive pills combined with progesterone, low ones as well, that will also suffice. Now, progesterone only pills have also been advocated. However, you know there's a very, very high failure rate.
Absolutely.
Yes, progesterone only contraceptive, but this could also be.
What of IUCD, the good old IUCD?
The good old IUCD, it falls under the MEC criteria 2 for diabetes. The only drawback is this complaint because women come back, they have recurrent vaginal discharge. I know, of course, diabetes also predisposes to infection and all that, but this is also an obtainable option as well.
Okay, thank you very much for that. So just before we conclude, I think this is second to the last slide. We can't keep our audience waiting now. So just an algorithm, the algorithm is actually really for diagnosis, not for treatment. Okay, so of course there are many approaches, and there's no one-size-fits-all approach. But the approach that is shown on this screen shows a pregnant woman. We talked about whether it's every pregnant woman we want to screen or those with some certain risk factors. But say every pregnant woman early in the antenatal clinic visits, do a fasting blood sugar even at the first contact, and based on that, you can say whether it's normal, whether it's abnormal, that's between 93 and 125 milligrams per DL, or whether it fits the criteria for overt diabetes. Okay, in the people that have it normal at this first contact, again at 24 to 28 weeks, you do a formal OGTT in them. This is a liberal screening approach, just screening almost everybody. And in those ones, if the OGTT is normal at that time, you just manage as a normal pregnancy. But if the OGTT is abnormal at that 24 to 28 weeks, you can make a diagnosis of gestational DM and then you treat as such. In people who have this 93 to 125 in pregnancy, that's an abnormal value in pregnancy, you can make a diagnosis of gestational DM already. Some of them are actually going to be pre-gestational, but it doesn't meet the criteria for the pre-gestational, and then we treat it as pre-gestational, and then you still manage as such for that. For people who have a fasting of greater than 126 in early pregnancy, that meets the criteria for diagnosing diabetes already, and it should be treated as overt diabetes in pregnancy. Okay, you should ideally repeat as you do outside pregnancy and get an A1C for this kind of people that meets this criteria for diabetes diagnosis. And for the people who during an OGTT, they don't just exceed the diagnostic criteria for gestational DM, but they meet the diagnostic criteria for DM in pregnancy. That's a fasting of greater than 126 or a 2-hour post-OGTT of greater than 200. That is pre-gestational diabetes in pregnancy. And of course, for people who have this GDM or pre-GDM, they should have the full standard care for GDM and diabetes in pregnancy, including an endocrinology and a joint, a multi-specialty referral to optimize their outcome. So I think that's just a summary of the screening process. Of course, who you screen now is debatable. Some people screen everybody. Sometimes it's not financially prudent to screen people who have some specific risk factors like we outlined earlier. So in conclusion, Dr. Nico.
So conclusively, the increasing obesity and older age in pregnancy now makes discussion on diabetes in pregnancy an important public health problem. And we must always focus on the glycemic control, because all maternal glycemic control can significantly increase maternal and fetal risk in pregnancy, and also the adverse outcome as well. And this has a negative effect on both mother and child, as we said earlier on. Now, the recent standardization, though may seem a bit blurred, is advocated because really it is based on the outcome. So each center should have a dedicated diagnostic threshold. We have one in Mimi Hospital, and then it helps you to work to achieve the good outcome that you really desire. Now, finally, we must not forget that there are long-term risks, and this requires follow-up for both the mother and the baby. Thank you so much.
Thank you, Dr. Nico. Thank you, everybody, for listening. We're just going to take some of the questions now. I'm so sorry that we took more of our time than we planned. I think we'll still continue to work on that a little bit. Someone asked here that does GDM fall under type 1, type 2, or the class, or type 2? Well, in the categorization of diabetes mellitus, there's type 1, there's type 2, there's other specific types, and then there is GDM. So GDM is in a class of its own because it's induced by pregnancy, and by definition, it resolves after pregnancy. So that's the heyday classification that was released, I think, more than 10 years ago. Why don't we use fasting sugar to screen instead of the often unpleasant OGTT? I think we answered that a bit during the presentation. The abnormality in GDM is primarily a postprandial abnormality. It's actually an excess surge of glucose after meals. The fasting, or in a fasting state, the patient is usually fine, and the glucose is usually relatively fine. So that's why you actually need to do a dynamic test for that. Can gestational diabetes be prevented in those at risk? The short answer is yes, fairly, because don't forget that gestational diabetes is partly related to the background beta cell function and the background extent of insulin resistance in the person. So if someone does things to reduce those risk factors of GDM, particularly the modifiable one, by controlling obesity, controlling sedentary lifestyle, even before getting pregnant, the risk of having GDM can be reduced to some extent. But it's not that will not be a 100% answer, because there's some things that you can't really fully control. For example, if someone has had IUCD before, you have family history of diabetes mellitus, which increases your risk for DDM, you can't really do so much about that. What other question here? What is the fasting and 2-hour postprandial target for GDM patients on insulin? The fasting target should be less than 92. Some guidelines say 95, but let's say 92 milligrams per DL for fasting. I'm not sure what that will be in the other unit, but we can convert by dividing by 18. And then the 2 hours postprandial should ideally be less than 125. Some guidelines use less than 120. So is that stringent? And I'll tell you that it can be difficult to attain such targets, particularly if you are used to the outside pregnancy target. So the targets are stringent, and the reason why these targets are chosen are based on maternal and fetal outcomes. Someone asked here that how often should the random blood sugar of a macrosomic baby should be checked, and how stable value should you check before you stop checking the random blood sugar?
Yes, we answered it. So early, once the baby is born, however, you are feeding the baby too early. If the baby is, if the baby qualifies to be fed, or the baby is set, an IV intravenous fluid is set for the baby, and then monitoring is early. Now, once the blood glucose stabilizes between 2-3 consecutive checks, then you can be safe assured that yes, the macrosomic baby has attained euglycemia, and then you, of course, you institute the normal feeding, too early feeding, etc.
Okay.
Yes.
Okay. So someone's asking, this is a OBGYN question. Any advantage of using folic catheter over using misoprostol for cervical right and IUL?
So we didn't go, because of time, we didn't go into the various mechanisms of cervical ripening. So use of misoprostol is also advocated for cervical ripening. You could use Foley's catheter. There are different things you could use, laminary tents, etc. So misoprostol is not contraindicated. In fact, you can even use synchronous cervical catheter with low dose misoprostol for ripening prior to induction of.
So there's no particular advantage of Foley's catheter over misoprostol.
There's been conflicting studies and results, so we can carry out our protocol as it's indicated.
Okay, all right, thank you very much. What's the value for hypoglycemia in a newborn? Can hypoglycemia be corrected with 10% dextrose water as a maintenance fluid? So you need to give a bolus for that. Yes, what's the value they use for hypoglycemia in a newborn?
Yes, I think I'm not too clear.
I'm not very sure about that myself. It's around 3. I know you asked me less than 3, but I can't remember the exact values. But we know that in a normal newborn, the glucose values are much lower than that of a older child. Okay, I wish the pediatrician was around.
And of course, they also look at the symptoms, because if the baby is jittering, sweating, etc.
Okay, so if you can find that answer,
but we don't use 10%. We can correct with a loading dose constituted from 10%. However, maintenance has to be with pediatrics say like, but I'm not.
So, but anyway, when we are correcting hypoglycemia, you need to give a bolus first before you do the maintenance. Okay, thank you, Sama. So the video of the presentation will be definitely on YouTube within the next 2 or 3 days or so. Okay, so I need more clarification on the role of A1C in GDM and DM in pregnancy. So the role of A1C again, number 1 is that it's limited. Number 2, it can serve as an adjunct for SMB, for the self-monitored blood glucose. Don't forget that self-monitoring of blood glucose has limitations as well. So the role of A1C, number 1, is can guide you towards glycemic control. We said that the target A1C in pregnancy should be less than 6.0%. Before pregnancy, you want it to be less than 6.5% before the person attains pregnancy. And if the A1C is grossly high before pregnancy, you want to counsel the person to still remain on contraception until the A1C is got into a safe range. Also, studies have shown that the higher the A1C before pregnancy, the higher the A1C during pregnancy, the more likely you are going to experience adverse outcomes. So basically that is it. It's an adjunct to SMBG, and it can give you it can be something that will prompt you to take other decisions. So someone, for example, is not checking SMBG adequately or more frequently enough, and then you're not sure whether you really want to start insulin this person, but you did the A1C and you got 7, please start. Okay, so that's the way that the HbA1c can guide us. But don't forget what we said about the HbA1c being relatively lower in pregnancy for the reasons we did mention earlier. The anemia, the increased red cell turnover, and the hemodilutions that happen in pregnancy. I think we'll take some of these questions in the chat box now. Let's see if there's any question here. Okay, so there's a question here. Is there a specific glucose level or A1C that guides in determining GDM for diabetes in pregnancy? Once your glucose level is high enough to meet the criteria of diabetes, of the classic normal diabetes, please diagnose diabetes. So if you have someone with a fasting of greater than 130, of greater than 126 and above, it is diabetes in pregnancy. That is not GDM again. And the implications is different because that's not the time to start talking about diet, and that's the time that you need to now hammer that. Now, this person must have an anomaly scan because you know that this glycemia is likely to have been there as at the time of conception, embryogenesis and organogenesis, etc. So, of course, if your A1C level 2 meets the cutoff for diabetes, it is diabetes. It's no longer GDM. GDM is a moderate amount of dysglycemia actually, and so I think that is just that, and it's shown on that algorithm that we use at close to the end of the presentation. Looking for any other question here. From the algorithm, is it every pregnant woman that should be screened with FBS and lethal GTT in second trimester? Is this for all population? No, it is not actually. The algorithm is just one of the approaches that people take. So in many clinics, I'm not even sure what Dr. Nico does in our clinic there, but in many clinics, it's actually people who have risk factors alone that would have that will have an OGTT, and definitely in many clinics you don't need to screen, do fasting sugar for everybody at the first contact. So this guideline will not apply, but it's just, don't forget that how we should screen people for diabetes in pregnancy is quite debatable, and there are a lot of opinions on this. There are vast amounts of recommendations for this. So this is just one of the described approaches. But I could say very easily on this algorithm here that where we have this every pregnant woman, it could easily be women with one or more than one risk factors for diabetes, and people that would choose to screen like that. So it's just one of the approaches that can be used. I, for one, would not recommend that you do fasting blood sugar for every pregnant woman. Probably not. I think in an environment like ours and in most environments, it would be more appropriate to screen people who have maybe at least one risk factor before we go do other things for. So thank you for highlighting that. It's definitely not for all populations. Now the unit for measurement of glucose, why in millimoles per liter not rather than the MT per DL? Well, unfortunately we're in Nigeria, and I'm not sure there's actually a great consensus of what unit should be used to measure glucose in Nigeria. I know in the center where I train, we do more of the milligrams per DL. In UK, they do more of the millimoles per DL. US, they do more of the milligrams per DL. So in different centers in Nigeria, and sorry for in this slide that we actually use both. I actually had to adapt myself to millimoles per liter, which I'm actually not used to before now. But I believe that all of us are able to convert from one unit to the other. And for my patients, I usually advise them to be familiar with the units that their glucometer shows, such that they don't have to be converting now and then each and every time. Thank you everybody for joining us. Thank you, Dr. Nico. It's been a fruitful discussion. Sorry that we took so much of our times. The presentation probably shouldn't have lasted this long, but I hope that we all got points there that would refresh us and help us to at least to be up to the task in dealing with our patients that have diabetes in pregnancy. There's just two more questions that popped up here. We'll just answer those before we call it a day. What's the advice? Would we advise for SVD in a patient who have history of macrosomic babies with a current clinical or estimated fetal weight of above 4.4 kg? What would you say to that, Dr. Nico?
Okay, so this answer is not straightforward. She's had previous macrosomic babies, so that pelvic has been tested.
Okay.
Now, you must bear in mind as the obstetrician in charge that shoulder dystocia is a complication that can occur, and that can lead to both neonatal complications and even maternal complications, which we highlighted. So some obstetricians will say, yes, I'll be there at the delivery, I'll take the delivery and I'll deliver this fetus and I'll be ready to take a shoulder dystocia delivery. Fine, that's fine. However, others will like to go through the lower threshold. No, I don't want this, I'll go for cesarean delivery. However, remember, a woman that has had previous macrosomic deliveries can have a macrosomic delivery of 4 kg without even having any complications. So the presiding obstetrician will need to take the decision. Now, remember, shoulder dystocia is not 100% predicted by weight. So you may have a 4 kg baby, the pelvis is adequate, delivery goes smoothly. However, it is a possibility and you have to be ready for it. Number two, we've highlighted the other reason. So it is a decision you have to take and you have to be ready for the outcome to have good fetal and maternal outcome.
So the last part, someone just asked that can only one of the risk factors necessitate screening for GDM? The answer is definitely. You don't need more than one risk factor. So by the time you are having a woman that is obese, has a family history of diabetes, has GDM in previous pregnancy, has a bad previous pregnancy, once you have one, definitely you have to screen. And I won't recommend waiting for more than one risk factor.
Sorry, to add very importantly, yes, now, as an addendum to that question, remember, fetal weight ultrasonically determined has a 0.5% chance of error. The same thing as the clinical estimation. So you also put this into mind as you are deciding what route of delivery you want to take.
Okay, thank you very much, everybody, for being part of this presentation. I think it's been a wonderful time. It's been refreshing for me, for preparing and participating in this presentation. I see a lot of diabetes patients, and it's a key component of what I do. And Dr. Nicole has always been there. We've managed a lot of patients together, gestational diabetes, a lot of good stories, but sadly, there's been a few bad experiences as well. And I think what that has done for us is actually geared us to not take anything for granted when we're managing this patient with diabetes and pregnancy. We should make sure we take meticulous time to educate them, control their glucose very well, plan. So it's been fruitful having this discussion once again, and discussion is coming from Mimi Hospital, Cardiochem Specialty Hospital, and thank you everyone for being a part of this.
Thank you so much.
The slides will be available when? In the next 12 hours, absolutely. In the next 24 hours. So within a very short time, the video will be on YouTube, and then the slides will be sent with the certificates of participation to our email address. So thank you all for joining us, and we hope that you have a very wonderful weekend.